Take a time, that makes sense.
All right. Hello, everyone, and welcome to the Neurocritical Care Society Pharmacy Section Journal Club. Today is Ischemic Stroke Day. We're going to have two very interesting articles presented by two PGY2s. I'm Jeff McSavage. I'm going to be the primary moderator for this program. Colleen Barthol is the brains behind everything and make sure everything is organized. So she keeps it in good line. And Keaton Smetana is going to be following us on Twitter or X and doing all that magic. I don't really know much about that, but he's going to be doing the magic there. And Corinne Berger, again, does a lot of behind the scenes things as well. So credit to all of these people. Our first speaker today are two PGY2s that we have. Allison Shawnock is from PGY2 critical care resident from the University of Florida Health in Jacksonville. And our second speaker today is going to be Hannah Noxon. She's a PGY2 critical care resident at University Health in San Antonio. And hopefully both of those places are warmer than the city of Chicago, where I am right now. But without more further to do on that, I'm going to turn it over to Allison, and she's going to be our first presenter.
Okay, well, thank you very much. Once again, my name is Allison Shawnick, that's like Sonic, but with a sh, and I will be presenting on the Optimus trial, which is the optimal timing of anticoagulation after acute ischemic stroke. It's important to note that around 20% of patients that have ischemic stroke actually do have atrial fibrillation present as well. And the major trials that looked at direct oral anticoagulants for AFib excluded patients that had recently experienced an acute ischemic stroke within the previous 7 to 30 days. So that really leaves a gap in evidence that results in the timing of resumption or initiation of anticoagulation to be variable and optimal practice is uncertain. Despite this gap in evidence, we do have guideline recommendations that are available. So the American Heart Association recommends the timing for DOAC after an acute ischemic stroke related to AFib to be somewhere between 4 and 14 days after the event. However, the European guidelines take a different approach, and they have staggered their recommendations in response to the severity of the stroke score. So you can kind of see that scheme listed on the screen, with it being 1 day after a transient ischemic attack, 3 days after a mild stroke, 6 after a moderate, and 12 days after a severe stroke. And it's of note, the European guidance is followed not only by the continent of Europe, but also Canada, Australia, the Middle East, and North African countries. So with this differences in timing in mind, we will look at some previous articles that have attempted to answer the same kind of question of when is the best timing. And speaking of timing, we do have the timing trial as one of those articles we'll be discussing. So this was an open label non-inferiority trial of 888 participants. The primary outcome was a composite of recurrent ischemic stroke, symptomatic intracranial hemorrhage, or all-cause mortality at 90 days. For this trial, early initiation was defined as within 4 days of the acute ischemic stroke, and that was compared to delayed initiation somewhere in the span of 5 to 10 days after the event. And they did find that early initiation was non-inferior to delayed initiation for the primary outcome. Additionally, there was a lower incidence in recurrent ischemic stroke for the early initiation group. Similarly, the ELON trial was an open label trial of 2013 participants in which the primary outcome was another composite looking at recurrent ischemic stroke, symptomatic intracranial hemorrhage, major extracranial bleeding, systemic embolism, or vascular death, but at 30 days. For this trial, early initiation and delayed initiation followed more of the European design where you have staggered initiation dates based off of stroke severity. And you can see those definitions on the screen. Once again, there was no significant difference in primary outcomes between groups, but there was a lower incidence of recurrent ischemic stroke in the early initiation group. So to put all of this together for these two trials, Early initiation was found to be non-inferior to delayed initiation in terms of those primary outcomes that were composites of both ischemic stroke and intracranial hemorrhage, as well as other bleeding and clotting type endpoints. And there was a lower incidence overall of recurrent ischemic stroke for the early initiation group. So that brings us to the Optimus trial itself and its study's purpose. So the study's purpose was to establish the safety and efficacy of early anticoagulation with the DOAC in a broad population of people with acute ischemic stroke associated with atrial fibrillation. This was a phase 4 multi-center parallel group randomized controlled trial. It was open label, but the endpoint adjudication was blinded. So the clinicians that made the final determination for whether or not any of the endpoints were reached were unaware as to the timing of the initiation of anticoagulation. So the people that were ultimately making those clinical calls did not know which dosing strategy the participants were placed on. This was a hierarchical non-inferiority superiority gatekeeper design study. And basically what that means is that the investigators tested for non-inferiority first and stated if non-inferiority was reached, they would then investigate superiority. For the purposes of this trial, early initiation is defined within 4 days of the stroke onset, and delayed initiation was categorized as 7 to 14 days from stroke onset. The enrollment period was between July of 2019 and January of 2024. And this study was conducted in the United Kingdom across 100 different hospitals. So to compare the Optimus trials design to those previous trials we were speaking of, it falls more in line with the design of the timing trial, where early initiation is categorized around that 4-day point, and delayed initiation is 7-14. Again, kind of a flat timing recommendation, no adjustment for the severity of the stroke as the ELON trial did. Participants were included if they were 18 years or older, had an echo or medical record confirmed disease state of atrial fibrillation. They had to have a clinical diagnosis of acute ischemic stroke with symptoms lasting for more than 24 hours. And they had to have imaging, either CT or MRI, to exclude intracranial hemorrhage, and then repeat imaging before initiation of anticoagulation. Participants were excluded if they had a known coagulopathy, recent or current use of a vitamin K antagonist resulting in an INR of greater than 1.7, thrombocytopenia with platelets less than 75, hemorrhagic transformation or intracranial hemorrhage unrelated to stroke, so any bleeding in the brain, a contraindication to a DOAC, renal or hepatic impairment, as you see there, pregnancy or breastfeeding, or the inability to follow up at 90 days. The endpoints for this trial were as follows. So the primary outcome was once again a composite, and the composite was comprised of recurrent ischemic stroke, symptomatic intracranial hemorrhage, unclassifiable stroke symptoms, and systemic embolism. So you may be asking, what does unclassifiable stroke symptoms mean? This is just if the clinical adjudicators found the participant had symptoms that were consistent with stroke, but imaging or additional information was not available for them to categorize it as a ischemic stroke or hemorrhagic stroke. So kind of a catch-all for those somewhat less clear cases. Secondary outcomes included the incidence of the individual components of the primary outcome, all-cause and cardiovascular mortality, incidence of venous thromboembolism, and then some more patient preference or patient status outcomes that you can see there. However, not all of these secondary outcomes do have results that were reported in this current publication. For statistics, this was an intention to treat population, and a power calculation was performed before enrollment of any participants, and they assumed a reduction in that primary composite outcome event rate from 11.5% in the delayed initiation group to 8% in the early initiation group, with a relative risk reduction of about 30%. Based off of this assumption, they planned for a sample size of 3,478 patients that would provide a 90% power for superiority, assuming a two-sided significance of 5% and assuming that 10% of participants would be lost to follow-up. That sample size would also power 80% for the non-inferiority margin. While initially the clinicians and investigators did set a 3% non-inferiority margin, at their interim analysis, they found that the event rate was lower than they had anticipated, and so they opted to accept a 2% non-inferiority margin instead. So looking at the participants of this trial that were included, your average participant was 78 and a half years old. Most participants were male, and the overwhelming majority of participants were white, at around 93 to 94%. So, not a very diverse group in terms of racial background. Rates of diabetes and chronic kidney disease were maybe lower than you would expect for the American population, diabetes around 20%, and chronic kidney disease around 15% of participants. Around 50% of participants did have atrial fibrillation that was known before this acute ischemic stroke. And of those participants, the most common type of atrial fibrillation was persistent atrial fibrillation, with that accounting around 70% of those that knew that they had AFib. When looking at agents that were utilized before this ischemic stroke, a very low portion of participants were previously on a vitamin K antagonist. Around a third of participants were previously on a DOAC, and around 10% of participants had previously been on an antiplatelet agent. Looking at the treatments that these participants received, around 20 to 23% did receive intravenous thrombolysis, and around 7 to 7.5% received an endovascular intervention. When looking at the severity of stroke scores at randomization for these participants, you can see that there's a nice, somewhat linear relationship where there's a higher prevalence of those mild stroke scores at randomization, and that follows down nicely. So, most participants having mild or mild to moderate symptoms, and very few participants having severe NIHSS scores at randomization. When we look at the agents that were initiated after this event that occurred, you can see the overwhelming, or maybe not, somewhat large majority of patients received apixaban, around 60%. Very low incidence of initiation of dabigatran or rivaroxaban. And then, somewhat differently from my practice area, at least around 30% of patients were initiated on edoxaban. The investigators did use a modified intent to treat analysis for their end statistics, and they said that they accepted patients that were placed on standard doses of these different agents. And that was further delineated in the supplemental material. So Pixaban 5 milligrams twice daily or 2.5 milligrams twice daily, dabigatran 150 milligrams twice daily or 110 twice daily, edoxaban 60 daily or 30 daily, and rivaroxaban 20 or 15 milligrams daily. And all of those in line with their various cutoffs for dose reduction. Antiplatelet agents were initiated or utilized in around 82 to 85% of participants. However, the authors did not define or further delineate which antiplatelet agents were utilized. So looking at our big results, our primary outcome, the primary outcome did have an event rate of 3.3% in both the early and delayed initiation group, causing that to be not significantly different, a very small confidence interval there as well for the adjusted risk difference. When we look at the individual components of the primary outcome, the story is similar, not a significant difference or large difference at all when it comes to recurrent ischemic stroke, symptomatic intracranial hemorrhage, systemic embolism, or those unclassified stroke symptoms. All-cause mortality also was not significantly different between the two groups and had very similar incidences. And so, not surprisingly, when you look at the primary outcome and mortality together, they were not significantly different. When looking at some of these secondary outcomes, major extracranial bleeding, not significantly different between the two groups. However, there is a slight higher incidence in the delayed initiation group. Again, not significant, but it's there. Non-major extracranial bleeding, again, no significant difference between the groups, but slight incidence increase for the early initiation group. All major bleeding, not different, but somewhat more prevalent in the delayed initiation group, but not significantly so. And venous thromboembolism, not significantly different, but more prevalent in the delayed initiation group as well. So to orient you to this forest plot from the article itself, we have different subgroups listed over here on the left. And in the middle here, we have our zero line with there being no favorites at all. On the left side, favorites for early DOAC initiation, and on the right, favorites for delayed DOAC initiation. And while it would be significant if this box and its error bars were clearly on one side of the zero margin or the other, you can see visually that none of them are. So there's no major statistically significant differences favoring one dosing strategy or another when we look at those subgroups. But you can see by where the box is placed what way the data is kind of pulling or favoring slightly, keeping in mind again that none of these are statistically significant. But somewhat surprising trend, the moderate to severe participants actually do have a slight favorance, albeit large error bars, for the early DOAC initiation strategy, which opposes the current European guidelines that say, oh, the more severe the stroke is, the longer we should wait to initiate anticoagulation. So I found that to be interesting. And when we look at the reperfusion treatment, those that did receive reperfusion treatment, again, kind of pulling towards favorites of early initiation. However, previous anticoagulation is really right in the middle there, and having received previous anticoagulation before actually pulls slightly towards favorites of delayed DOAC initiation. So this brings us to the author's conclusions, and they concluded that early initiation of a DOAC is non-inferior for the primary composite outcome of ischemic stroke, intracranial hemorrhage, unclassifiable stroke symptoms, or systemic embolism at 90 days. They stated that there was no increase in the risk of intracranial hemorrhage or reduction in the risk of recurrent ischemic stroke. So while those other studies did see a slight reduction in the risk of recurrent ischemic stroke with early initiation of DOAC, the authors said that they did not. But they did note that their findings do not support delaying the initiation of a DOAC because of concerns about the risk of early intracranial hemorrhage, particularly in people with moderate to severe stroke, as the guidelines recommend. So once again, while the European guidelines, the UK is in Europe, so their guidelines recommend delaying initiation of anticoagulation for those more severe strokes, they said their findings really oppose that notion. So this trial did have many strengths and weaknesses. Some strengths were that it was a large, multi-centered, randomized controlled trial that investigated relevant clinical endpoints. I was impressed that the authors actually over-enrolled compared to their initial power calculation. So they were aiming for 3,478 participants and ended up with 3,621. And also I felt that the gatekeeper design, where you test for that non-inferiority margin before investigating superiority, was appropriate. However, there were several weaknesses as well. One of them being that the receipt of both intravenous thrombolytics and an endovascular intervention was not specified. So both in the body of the text of the main manuscript and in the supplement, they state that they will be looking at those that received IV thrombolytics and endovascular intervention individually and both. However, when we get the reported data, they do not have rates or any analysis on patients that did receive both the thrombolytic and an endovascular intervention. So that's kind of a missing piece of information when thinking about generalizing to a patient that may have received both of those interventions. Another weakness is that DVT prophylaxis rates, dosing strategies were not reported on. So what those patients were receiving prior to their full anticoagulation is unclear. And if this DVT prophylaxis strategies were vastly different between these different 100 hospitals or between early and delayed initiation, this could potentially impact results, but that's not something that we have information or access to. Additionally, they performed a 90-day analysis looking at all of these different outcomes, and a big part of their follow-up was over the phone or face-to-face when able. So I would have liked to see some information at 30 days as well. I think that would have been feasible and would be informative to have. Also, they did have a lower than anticipated event rate. So initially in their pre-specified power calculations, they expected about 11.5% for the primary outcomes event rate in the delayed group and around 8% for the early initiation group. However, both groups ended up having a 3.3% event rate, so much lower than anticipated. So, what does all of this mean for us and our patients? What's the clinical interpretation? I think the first big thing to think about is the generalizability of these findings to the United States population. So, in terms of comorbidities, these participants that were included in this study had a lower incidence of diabetes and CKD than I would expect in the average American population, which is important to think about. Additionally, another large difference between the UK and the US is that the United Kingdom does have universal health care, and their medication access situation is different from ours. So they actually found 95% adherence to the assigned DOAC from participants at that 90-day point, which is really impressive. However, this metric was based off of patient-reported um, adherence. So the patient said that they were taking it or not, but still 95% is a large percent and maybe not realistic for uh, our patients over here. Thinking about the demographics of this patient, this was an older adult population with the average patient being 78 and a half years old, and most participants were male, and the overwhelming majority of participants were white. So thinking about generalizing that to patient in front of you that may not have those same demographic features. Another thing that's worth noting is almost a third of the participants were initiated on edoxaban, which is not as commonly utilized here, but most participants were initiated on Pixban, which is pretty common. Other considerations I would take into account is the distribution of stroke severity scores. So most of the participants that were included did have mild stroke symptoms, around 0 to 4 on their NIHSS score. And then the most common category after that was that mild to moderate, up to 10. So when thinking about generalizing this to a patient with more severe symptoms, it's important to note that most of these patients were on the mild or mild to moderate side. It's also worth considering the rates of thrombolytic receipt or endovascular interventions that were present in this study compared to your institution. So they had thrombolysis rate of around 20% and endovascular intervention around 7.5%. At my institution, at least, both of those interventions have about 15% prevalence. So thinking about how this study may compare to your practice site. Another consideration would be the generalizability of these findings to parenteral anticoagulation. So for logistical purposes, many patients are not a candidate to be started on DOAC this early if they have really high deficits or burden from their stroke. So they may need enteral access placement through feeding tube, they may need trach placement, and providers are not comfortable with doing these procedures while the patient's on DOAC. So for feasibility, fast on purposes, those patients may need to receive parenteral anticoagulation for some time until all of those things have been taken care of. And this study doesn't really address whether or not that would be appropriate. It's limited generalizability to that type of situation. Additionally, we looked at within 4 days and then in the 7 to 14 days category, but what about days 5 and 6? So if day 5 or 6 was the optimal time to initiate a DOAC, that wouldn't be captured in the design of this study. So that remains kind of an unanswered question. And so while these findings differ from both the American and European guideline recommendations, they are consistent with similar recent literature, that being the timing in the ELAM trials. My takeaway points, I do believe that the study design and execution was appropriate. However, the majority of strokes were mild or mild to moderate. I would say in patients with AFib without a contraindication to a DOAC, known coagulopathy, renal failure, or other exclusion criteria from this trial, I think it is reasonable to start anticoagulation with the DOAC within 4 days of a mild or mild to moderate acute ischemic stroke related to atrial fibrillation. Some future research areas would be to include patients with renal or hepatic failure, or look at the optimal timing of patients requiring warfarin. And I do think that the same exact design as this study, but looking specifically at patients that received an intervention of either IV thrombolytics or an endovascular intervention would be worth noting, since there's a relatively low number of those patients included for this trial. And with that, I would be happy to take any questions.
If you're brave, you can go ahead and put your microphone on, and we have a small group here, so I think it'd be nice to just ask some questions of our speaker. If you want to put them in the chat, I can also do it that way. Also, we have a Twitter X feed going on at #NCS FarmJC. So make sure that all of you fans of X and Twitter or whatever it's called, go ahead and on there and are following that as well. So Allison, looking at the kind of the data and stuff, I'll start off with a little something. Do you really think there's a rush to go ahead and start these DOACs? I mean, the literature from here, we kind of see this. They wanted to find a benefit. It wasn't there. I know what you concluded, but looking at some of these things, is there really a rush to go ahead and start these DOACs? And I like to wait. Can I be more patient? What do you think?
I think that's a great question. And I think what's important to keep in mind with delaying any intervention that we know to be helpful, whether that's DOACs in atrial fibrillation or uptitration of GDMT, is that if the patient gets traded to a different service or we have a transition of care or transition of team, these things get delayed further and sometimes not optimized. So I would say the risk in delay of something that we know to be helpful is always like, not now, then when? If it's not okay for it to be now, then why wouldn't you go ahead and start something that's known to be helpful? So that would be my counterpoint. However, overall, there's no significant difference. There's non-inferiority, but the superiority margin wasn't reached for this trial. So I would say if you're confident that you can get it within those 14 days, is there a major rush? Not necessarily, but also keeping in mind feasibility and how we need to be careful when we're pushing things off at the same time.
So we have to fix ourselves to fix the systems that we work in, not necessarily the data. I think that's good. Does anybody else have any questions for our presenter? Chad, following us on Twitter, X, feel free to put your microphone on. It's a very small group. Nobody's going to be biting here. We can just go ahead and put yourself out there if you have a question.
Hey, Jeff, I have a question here. Thank you, Allison, your presentation. So I'm curious, the authors mentioned that the limitations of some of the currently available literature include the fact that most of the data is in patients with like more milder strokes. And so I'm curious, like, what are your thoughts after looking at this trial in terms of using the strategy in your patients with more moderate to severe stroke?
Yeah, I do think that same limitation does apply to this trial as well. So the most common category of an AHSS score was that 0 to 4 for this trial as well. So I would say that same limitation still applies, where the majority of their participants were in the mild category or the mild to moderate category. So I still think that there is limited generalizability to more severe strokes. And it is difficult to take something that doesn't include that population as robustly as we'd like and say that that's going to be what opposes current practice or guideline recommendations. So I do think that is still a limitation in this field.
All right, Allison, it's a quiet group, so I guess we're thank you so much for your presentation, and I think we're going to move on to our next article. The next article we have is by Hannah. Hannah, you can go ahead and put your slides up.
I just realized I was muted. Can everyone see my slides okay?
Yep, they look good.
All right, perfect. So hi, everyone. My name is Hannah Noxon. I am currently a PGY2 critical care resident at University Health in San Antonio, Texas. And today I will be presenting a journal club on the TREND trial, which is tirofiban for the prevention of neurological deterioration and acute ischemic stroke. So acute ischemic stroke is the fifth leading cause of death in the United States, with an estimated that about every 40 seconds, somebody in the United States has a stroke. More than 690,000 strokes are ischemic in nature, which is about 86% of all new and recurrent strokes every year. It's the leading cause of long-term disability, and it reduces mobility in more than 50% of stroke survivors age 65 and older. Early neurological deterioration is defined as a progression of neurological impairment within the first few hours to days following acute ischemic stroke onset. There's no consistent definition for this, but some define it as an increase in the NIHSS score, the National Institute of Health Stroke Scale score, greater than or equal to 4 at 24 hours from baseline. And this has the highest incidence at 24 hours of admission. Up to 40% of patients with ischemic stroke can develop neurological deterioration, and it significantly impacts their long-term clinical outcomes. The etiology of neurological deterioration is unclear, but we think it may be related to worsening ischemia. It can occur even after IV thrombolysis, which we may think is related to failed recanalization, distal thrombus migration, arterial reocclusion, or recurrent embolic events. Tirofiban is a glycoprotein 2B3A inhibitor, and it's FDA approved for non-ST elevation myocardial infarction to help reduce the rates of thrombotic cardiovascular events. However, it has limited benefit on ischemic outcomes or bleeding complications, which limits its use in that area. Its use is considered in high-risk patients before undergoing percutaneous coronary intervention or PCI. Glycoprotein 2B3A inhibitors work by preventing platelet aggregation. The drug is able to block the glycoprotein 2B3A receptors on the platelet's plasma membrane, inhibiting fibrinogen binding. Tirofiban inhibits ex vivo platelet aggregation in a dose and concentration dependent manner, and it has a half-life of about 2 hours. 90% of platelet inhibition is attained within about 10 to 30 minutes, depending on the dose that is administered, with higher doses achieving faster platelet inhibition. And in most patients, ex vivo platelet aggregation returns to near baseline at about 4 to 8 hours after the drip has been discontinued. The 2019 update on the guidelines for early management of patients with acute ischemic stroke from the American Heart Association and American Stroke Association recognized glycoprotein 2B3A inhibitors, but they have limited evidence to support its use. They recommend against abciximab as it was associated with a higher risk of intracerebral hemorrhage with minimal benefit. However, they do recognize a need for further trials for tirofiban and efabibitide to determine their utility in acute ischemic stroke. So now I'm going to go into some background literature. The first trial is a trial called the SETIS trial, which is the study of efficacy in tirofiban in acute ischemic stroke, which was published in 2010. The trial reviewed patients with acute ischemic stroke onset within 6 hours, and patients were administered either tirofiban at 0.6 microgram per kilogram per minute for 30 minutes, followed by continuous infusion of 0.15 microgram per kilogram per minute for 72 hours. And that was compared to patients who received aspirin at 300 milligrams a day for 3 days. This trial was stopped early due to a lack of difference in efficacy between the group in terms of neurological outcomes. As for safety outcomes, they did notice higher rates of intracranial hemorrhage in the tirofiban group, although there was no significant difference between tirofiban and aspirin. The second trial was published 1 year later, and it was called the SATIS trial, or the Safety of Tirofiban in Acute Ischemic Stroke. This study reviewed patients who had acute ischemic stroke onset within 3 to 22 hours who were not eligible for thrombolysis. These patients received a different dose than the previous trial at 0.4 microgram per kilogram per minute over 30 minutes, followed by a 0.1 microgram per kilogram per minute for 48 hours. And this was compared to placebo, which was just normal lean. This study showed no difference in parenchymal hemorrhage or hemorrhagic transformation between the two groups. However, they did notice lower mortality after 5 months with patients that were treated with tirofiban. Last but not least, for a background trial, I have the 2023 Rescue BT2 trial. This trial looked at patients that had acute ischemic stroke without a large or medium-sized intracranial vessel occlusion with an NIHSS score greater than 5, indicating a moderate stroke or more severe than that. They also had to have one following that is listed below, which includes various time frames and included patients that may have received thrombolysis therapy or thrombectomy, but did not show improvement, which is very different than some of the other studies that actually excluded those patients. Tirofiban was given at 0.4 microgram per kilogram per minute for 30 minutes, followed by 0.1 microgram per kilogram per minute for 48 hours, and this was compared to aspirin dosed at 100 milligrams a day for 2 days. For outcomes, they looked at modified Rankin scale, which the modified Rankin scale is a tool that is used to measure the level of disability after a stroke or other neurological event, with higher scores indicating disability. There were significantly more patients that had lower scores on the MRS scale with tirofiban at 90 days, which indicated less disability from the acute ischemic stroke. However, they did show a significantly higher incidence of cranial hemorrhage with tirofiban in this study. So this leads to our next study that we're going to be talking about today, which is the TREND trial, which is the effects of tirofiban on neurological deterioration in patients with acute ischemic stroke. The purpose of this trial was to determine if intravenous tirofiban administered within 24 hours of stroke onset prevents early neurological deterioration in patients with acute non-cardioembolic stroke compared to oral aspirin. Additionally, they aimed to assess whether tirofiban can prevent early neurological deterioration without increasing the risk of symptomatic intracranial hemorrhage. So this study design was an open label randomized control trial that was taken place at 10 different comprehensive stroke centers in China. Patients were randomized in a 1-to-1 fashion to IV tirofiban or oral aspirin. The IV tirofiban had very similar dosing to 2 of the previous studies that are just mentioned at 0.4 microgram per kilogram per minute for 30 minutes, followed by a continuous infusion of 0.1 microgram per kilogram per minute for up to 71.5 hours, so a total of 72 hours. The comparator group was oral, dosed anywhere from 150 to 300 milligrams per day. After 72 hours, all patients were transitioned to oral aspirin with a 4-hour overlap for those patients that were transitioning from tirofiban to aspirin. In the aspirin group, the patients were on the 150 to 300 milligram a day dose for 2 weeks, and then they were transitioned over to some preventative dosing, which ranged from 100 to 300 milligrams per day. In terms of patient population, patients were included if they were adults aged 18 to 80 years old, if they had an NIHSS score of greater than or equal to 4 and less than or equal to 20, so that includes our more moderate to severe group and excludes our mild and very severe stroke scales. Patients were included within 24 hours of symptom onset or last known well time, and patients were included if they had the ability to actively move the muscles in a paralyzed limb with a standardized motor examination rating scale of greater than or equal to 2. Patients were excluded if they had intravenous or endovascular thrombectomies, if they had acute ischemic stroke due to suspected or existing cardioembolism, if they had active or known bleeding, if they were pregnant or breastfeeding, had uncontrolled hypertension, chronic hemodialysis, cirrhosis, congestive heart failure, or major trauma or surgery within a month. For efficacy outcomes, the primary efficacy endpoint was early neurological deterioration, defined as an NIHSS score increase of greater than or equal to 4 points within 72 hours of randomization. And this score was compared to the score prior to randomization. For secondary efficacy endpoints, this included early neurological deterioration, defined as an NIHSS score greater than or equal to 2 points within 72 hours of randomization. Early improvement, defined as a decrease in greater than or equal to 4 points within 72 hours. Level of disability at 90 days utilizing that modified Rankin scale. Excellent functional outcome at 90 days. Functional independence at 90 days. And change in NIHSS score from baseline at 24, 72, and 7 days, or 24 hours, 72 hours, and 7 days. For safety outcomes, the primary safety endpoint was symptomatic intracranial hemorrhage within 24 or 72 hours after randomization, which symptomatic intracranial hemorrhage was defined as any intracranial hemorrhage as the predominant cause of clinical deterioration with an NIHSS score increase of greater than or equal to 4, or an intracranial hemorrhage leading to death. Secondary efficacy endpoints included death from any cause at 90 days, incidence of intracranial hemorrhage within 72 hours of randomization, systematic bleeding within 72 hours of randomization, and any adverse effects within 90 days. The sample size estimations were based on previous trials and assumed that early neurological deterioration incidence of about 20% in the oral aspirin group, and an absolute difference of 10 percentage points between intravenous tirofiban and oral aspirin, which also can be explained as an expected 50% decrease in the treatment effect. A sample size of 420 patients was required to provide 80% power to determine the expected treatment effect, assuming a 5% attrition rate. The population for this study included the modified intent to treat population for all efficacy outcomes, a safety set population for the safety analyses, and a pre-specified sensitivity analyses were performed using a full analysis set. So patients were enrolled in the study between September 2020 and March of 2023. 682 patients were assessed for eligibility, with 256 patients included. 426 patients were left to be randomized, with 214 being randomized to the tirofiban group and 212 being randomized to the aspirin group. However, one patient in the tirofiban group was lost to follow-up, leaving 213 in that modified intention to treat analysis. For baseline characteristics, they had very similar baseline characteristics between the two groups. There was about an average age of 64 in each group. Majority of the patients in the study were male and compared to female participants. Greater than 30% of patients in this study were on some sort of antiplatelet agent prior to admission, with majority of those being on single antiplatelet therapy. Baseline median NIHSS score was a score of 5, indicating moderate stroke. The majority of acute ischemic stroke locations were located in anterior circulation, with about 59% in the tirofiban group and 52% in the aspirin group. The primary stroke cause between the two groups were majorly the large artery atherosclerosis and small vessel occlusions. And in total, greater than 50% of patients were randomized within 12 hours of symptom onset. So a lot of those patients were actually randomized earlier on rather than the 4-hour symptom onset. Most of them were randomized within 12 hours. So for our primary it was early neurological deterioration, again defined as that NIHSS score increase of greater than or equal to 4 points within 72 hours. And patients in the tirofiban group had a significantly lower rate of neurological deterioration within 72 hours compared to the aspirin group, with 4.2% of patients in the tirofiban group and 13.2% in the aspirin group, giving us a significant p-value of 0.002. For secondary endpoints, the first secondary outcome was early neurological deterioration with an NIHSS score increase of greater than or equal to 2, which was statistically significant in favor of tirofiban with an incidence of 11.7% in the tirofiban group and 23.6% in the aspirin group, indicating a significantly lower rate of neurological deterioration or stroke. The modified Rankin score at 90 days, the NIHSS score from baseline to various time points, and early improvement, defined as an NIHSS decrease in score by greater than or equal to 4, were not significant between the two groups. For the safety analysis, 14 patients in the aspirin group received intravenous tirofiban after neurological deterioration occurred, and these patients were then included in the tirofiban group for safety analysis. There was no difference between safety endpoints, including the primary safety outcome of significant or symptomatic intracranial hemorrhage, defined as any intracranial hemorrhage as the predominant cause of clinical deterioration or leading to death. There was no significant difference also in overall death between the two groups, any intracranial hemorrhage, or serious adverse effects or bleeding events. So for the subgroup analysis, we have subgroup analysis listed all to the left of all of the different groups, including age, sex, antiplatelet therapy, occlusion location, NIHSS, and time from onset to randomization, and stroke subtype. For this forest plot of subgroup analyses, all subgroup analyses favored tirofiban. However, some did not meet statistical significance due to a lack of power. However, the ones circled in red did show significance, and that included patients aged greater than or equal or greater than 60, those who did not have any prior antiplatelet use, those with anterior circulation stroke, an NIHS score less than 10, onset to randomization of greater than 12 hours, and those whose stroke subtype was a large artery atherosclerosis. So the author's conclusion, tirofiban overall lowered the risk of early neurological decline in patients with non-cardioembolic ischemic stroke when given within 24 hours of symptom set. Tirofiban did not increase the risk of intracerebral hemorrhage or systemic bleeding. However, they did say that further evidence is needed to determine the efficacy of tirofiban for all those functional outcomes. So some strengths of this study: it was a large randomized controlled trial that included 425 patients. The investigators in this study were blinded, and they used the same 2 investigators to determine baseline and follow-up NIHSS scores, which allowed for consistency, and any disagreements were resolved either by consensus or by a third investigator to make that final decision. The therapy in the study was initiated within 24 hours of symptom onset, which I think is really great. It fills the gap of those patients that don't meet that window for thrombolysis. So it includes those patients and gives them an alternate mode of therapy. And finally, they utilize patient-centered outcomes to show efficacy for long-term effects like disability. However, this study did not go without limitations. It was an open label design. And this study excluded patients with severe presentations who are outside that window of thrombolysis, which limits treatment options for those patients who are experiencing severe stroke symptoms. The study also has some limited generalizability. The study was based in China, and the Chinese population of patients actually have a higher incidence of intracranial artery stenosis in comparison to other cultural groups, which makes this study hard to extrapolate to, for example, the United States population. And then finally, the study had a lack of reporting on monitoring parameters like laboratory markers, which are recommended for use when using this agent. So even in the supplemental, there was no notation of any laboratory markers that were recorded. So clinical relevance, this drug has a very quick onset of less than or about to 30 minutes. So it works very fast. We can get that antiplatelet agent working pretty quickly in comparison to some other options. Platelet aggregation can return to baseline fairly quickly within 4 to 8 hours after discontinuation. This drug has a relatively low incidence of adverse events or safety outcomes as seen in this trial and some of the others. And this drug may be used in patients with acute ischemic stroke who are not eligible for thrombolysis or thrombectomy. So takeaway points, tirofiban use showed significantly lower rates of neurological deterioration within 72 hours of stroke onset in patients who were unable to receive thrombolysis or thrombectomy. They provided similar safety outcomes as aspirin in the studied population. However, further studies are required to determine those long-term functional outcomes of patients with acute ischemic stroke. And that's all I have. Thank you so much for listening and open for questions.
Thank you, Hannah. So we'll open it to any questions from the audience in the chat, or if you want to put your microphone on. It's a small group. We can go ahead and handle that. Hannah would love to hear from you, and someone other than me or Colleen would be nice.
Hey,
There's
Hannah.
Nick
Can
Peters.
you all hear me?
I can hear you.
Great presentation. My question is specifically about the GP2B3A inhibitors. For example, like our agent is eptifibatide on our formulary. So do you think it's appropriate to take the findings from the use of this agent and kind of extrapolate it if health systems have 3A inhibitors on their formulary?
I think you cut out a little bit, but I think I got the question. You're just asking like if, if on formulary we don't have tirofiban and we have eptifibatide or integralin, would you be willing to use that agent? I think that this can be extrapolated to eptifibatide. I actually asked our neuroclinical team if they actually have ever used it, and that is on our formulary as well as eptifibatide. And so I think that this can be extrapolated to use of that if that is on your formulary and there is restriction for tirofiban. Fortunately, that's just where a lot of the trials really lie is with this drug. But I think formulary restrictions, I do think that that can be utilized if that is what is available in those high risk situations where you want to administer something.
Anybody else out there have any questions for the presenter? I was wondering, Hannah, I think the hard part about stroke studies for me always was trying to compare apples to apples, and the population that, at least as it relates to stroke type, seems a little different to me. There were more large occlusions in, I think, the aspirin group. What do you make of that? Did that affect the results? Can that affect the results? Should we be worried about that? Or back to the generalizability of using this agent in this kind of, stroke?
Yeah, no, I definitely think that can be a factor that can alter the results. I mean, if the patients in the aspirin group had a larger amount of large vessel occlusions in comparison to the tirofiban group, that definitely can make your results look a little bit better for the tirofiban group with having a less severe stroke, or less involvement of ischemic stroke. So I definitely think that that can affect the results. I would definitely be interested to see if any other trials can, try to compare, like have those groups be a little bit more similar in future studies. But yeah, I definitely think it can alter those results and make tirofiban look a little bit better in that regard.
Yeah, Hannah, I think what's interesting for me too is if you look at the primary efficacy endpoint and look at the
Mhm.
rates of or early neurologic deterioration, and we did see a difference there, but it doesn't translate into like the clinical outcomes of like changes
Mhm.
in modified Rankin score, which, you know, with stroke trials, you know, a lot of people are looking for those clinical outcomes in terms of like, what is the morbidity, you know, of those patients? What does that patient look like post?
Yeah, yeah, no, I agree. That's a very good point. Ellen.
Also, just one side from Hannah, it was really good. I just wanted to double check because many patients sometimes, like we have it on adapt therapy and they want to go for trach and pegs or EVD removal. And at
Mhm.
that point, we have to put them on agrostat and stop the drips. And then afterwards, we resume the oral therapy again. This repeated exposure to agrostat is causing something like agrostat-induced thrombocytopenia, which was actually, I saw it on my patient student happen that the thrombocytopenia was really real, and then it took a
Mhm.
really long time to recover. So that's why this shows, by her articles, it shows that multi-exposure to agrostat, it can cause this. So that's why I wanted to make
Mhm.
sure if you start exposing everyone as early as this article is recommending to agrostat as early, then what will really happen to all this like second exposure and third exposure, and eventually causing this thrombocytopenia on many other people down the line.
Thank you so much for bringing that up. It's a very good point. And I think that's one thing I really wish that they did document in this trial is like those laboratory markers again, to kind of see that incidence of thrombocytopenia in these patients if they did experience that. But thank you so much for bringing that up.
Any other questions from the audience? Anybody else out there? Or the Twitter world, I guess, that's actively messaging each other. Well, without any, I don't see any. So Hannah, it looks like you're off the hook. So I would like to take this opportunity to thank both our speakers, Allison and Hannah, for a great job. Two PGY2 residents in critical care, and I hope they're aspiring neurocritical care pharmacists because you did a great job today. Thanks everybody for coming today. It was great moderating and great to see everybody. And I wish you all the best.
Thanks for having us.
Yeah, thank you so much. Have a great day, everyone.